Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and the Sarah Cannon Research Institute in Dallas, Texas. And I welcome you to this activity entitled Challenging the Confines of Risk of Recurrence in High-Risk HR-Positive, HER2 Negative Early Breast Cancer. And it's a great pleasure to be joined today by Priya Rastogi, who is professor of medicine at the University of Pittsburgh School of Medicine in Pittsburgh, Pennsylvania, and Seth Wander, assistant professor of medicine at the Harvard Medical School and Massachusetts General Hospital in Boston, Massachusetts. Hi, Seth and Priya. Great to be here with you both. So today we are going to talk about high-risk early stage breast cancer that's HR positive, HER2 negative. We have a big issue that these patients still with our optimal chemotherapy and endocrine therapy, by 5 years, at least 30% of these patients who are in that high risk category will recur of their breast cancer and ultimately die of it. So how do we define high risk? And how do we identify these patients in our practice? Well, we have two really important adjuvant CDK4/6 inhibitor trials that have defined high risk for us. And we'll talk about those trials here today. We're going to talk to Seth and to Priya today to see what they think about risk in their practice. And if we tweak the variables, what really still strikes them as high risk. So Monarch E, adjuvant abemaciclib, about 43% of the patients were premenopausal, 95% of the patients had had prior chemotherapy. As I said, 4 more lymph nodes positive, or if they were 1 to 3 nodes positive, grade 3 or 4 disease, there was another cohort, 517 patients that had 1 to 3 nodes positive in either grade 1, grade 2, or T1, T2, but they had a high Ki67, 20% or higher. And then the NATALEE trial included that same high-risk population, but also extended the eligibility to an intermediate risk population. 28% of the patients were premenopausal, 88% of that population had had prior chemotherapy, and 89% of the patients in NATALEE were node positive. And again, anyone node positive was eligible. If they were node negative, they had to be T3 and 0. If they were T2, they had to be grade 2 and have a high Ki67 or high genomic score. So intermediate or high risk population. And both of these options for our patients are category 1 preferred options on the NCCN guidelines, based essentially on the eligibility criteria for the 2 trials. And ESMO 2025, we had updates of the Monarch E and the NATALEE efficacy data. And at Monarch E now, we have 76 months of median follow-up, 2 years of treatment of the abemaciclib. There's a 77.4% IDFS rate with the addition of the abemaciclib compared to 70.9% without the abemaciclib. And so that is almost a 7% improvement in IDFS. Importantly, and for the first time, we saw statistically significant overall survival advantage in the intent to treat population of 1.6% with a hazard ratio of 0.84. And that is statistically significant. And the curves are continuing to split. It looks like with more follow-up, it'll be a larger number, very likely. And then with regard to NATALEE, we have 55 months of median follow-up. Of course, that's 3 years of therapy. And there is at 5 years an 85.5% IDFS rate with the addition of the ribociclib compared to 81% without the ribociclib. And that's a 4.5% absolute improvement with a hazard ratio of 0.7, and it's highly statistically significant, including in the node negative and the node positive population. And survival are immature and are not statistically significant. And then, of course, we know there are toxicities. We have to manage diarrhea with abemaciclib, and we also monitor the CBC and the liver function test. And Natalie, we monitor the CBC, liver function test, and 2 EKG. So we're all very familiar with the toxicities of these agents. So I really want to ask my colleagues, how do we practically identify these patients in our practice? Why are these patients high risk in our mind? And let's start with a case. So let's talk about this patient who's 56 years old, HR positive, HER2 negative, early breast cancer, grade 2 disease, 2 positive nodes with a tumor size of 5.1 centimeters, a Ki-67 of 35%. So she has now completed surgery and chemotherapy, and she may receive radiation therapy as well. So let me start with Seth. So Seth, how do you view this patient's risk of recurrence?
Thanks, Joyce. I think as you nicely outlined a moment ago, across these 2 trials, there are quite different inclusion criteria. The way that I try to think about this is anybody who met criteria for Monarch E would have also met criteria for Natalie. And then there's an additional subgroup of what I would call kind of moderate risk patients who would have also met criteria for Natalie. And so in this particular patient, we have a number of factors that I think all of us would agree put her in the high risk category. She has 2 positive lymph nodes. She has a T3 tumor measuring more than 5 centimeters, and she has an elevated Ki-67 of over 30%. So by all of those metrics, I think we would view her as high risk, and she would have clearly met criteria for the Monarch E population with 1 to 3 positive nodes and a T3 tumor and a high Ki-67. So she would have met 2 of the additional criteria that she needed to meet. And I think those are the factors that I would view as defining her risk profile. And these are the sort of things we would talk about when we first meet with the patient, to think about how do we define low, moderate, high risk? What's our approach to adjuvant anti-estrogen therapy in that context? And who would qualify for adjuvant CDK blockade with either ribociclib and or abemaciclib?
Thank you. Thank you, Seth. Priya, what do you think about her risk? And are there any other factors that come to mind that might modify her risk?
Yeah, thank you, Joyce. So other factors that we would also need to consider is if the patient had a genomic assay and whether she's high risk based on that genomic assay, also her overall health and potential comorbidities, and then adherence to therapy. As Seth said, we would have to talk to her about taking oral therapy with the CDK4/6 as well as anti-estrogen therapy and about compliance to this therapy. Other factors to consider are some of her lifestyle issues, and then accesses or limitations for transportation, able to get to appointments for follow-up, insurance, or even support systems within her network when thinking about adverse events.
Yeah, it's really multifactorial, this approach to thinking about the best therapy for her, but she certainly is high risk based on the Natalie and the Monarch E criteria. So we'd like to offer her a CDK4/6 inhibitor for sure. And so, Seth, let me ask you this: if she's 44 years old instead of 56, does that change how you think about her treatment?
I think it's a great question. I'm gonna try to answer this 2 different ways. I'm gonna answer this globally in terms of how we might think about her age and risk stratification with regard to both anti-estrogen and CDK inhibitor therapy. But then I'll also answer it with regard to Natalie and Monarch E in particular, since that's what we're talking about today. Let me start just with my own opinion about the global approach here. I think most of us would agree that if we had younger patients, premenopausal, perimenopausal patients, we might view that as kind of an additional risk factor. And when I talk to the patients, sometimes I'll view this as kind of the length of time that we're looking at potential recurrences. So if you have a patient who's in her 80s and has a number of active medical comorbidities, and perhaps her life expectancy is somewhat more limited, then we're not as worried about these distant late recurrences that are going to happen 10, 20 years later. When you have younger patients, not only do they often have clinical, pathologic, genomic features that are higher risk, but they also have a much longer kind of runway of time that we're trying to attenuate risk over, looking at decades. And so many of us would think about treating more aggressively with younger patients for that reason. And I think this is a good example of that. Obviously, for a patient like this who's got multiple positive lymph nodes, large tumor, high Ki-67, I would be thinking more about optimizing endocrine therapy, integrating ovarian suppression, trying to get her onto an aromatase inhibitor, extending the duration of the aromatase inhibitor, and integrating CDK blockade. Now, both the Natalie study and the Monarchy study, as we just reviewed a few moments ago, allowed pre- and postmenopausal patients. And so I don't think that her age per se changes my approach to the adjuvant CDK inhibitor, because she would have been allowed on both trials. I think we want to optimize endocrine therapy. We want to get her on ovarian suppression if she's pre or perimenopausal. And the last point I will make is that we obviously can't give tamoxifen with ribociclib due to some of the EKG and QT related risks. So the age here, I think, impacts our approach to risk mitigation. I think it impacts our approach to which endocrine therapy we use, and we have to be thinking about drug-drug interactions in terms of tamoxifen and the CDK inhibitors we choose if we are forced to go down that route.
Thank you. Thanks a lot, Seth. That's great. And so, but Priya, what if she were 76 years old? Does that change her risk in your mind? And how about how you would approach treatment for her?
So for a patient who is 76, in the same scenario, she would be eligible to receive either abemaciclib or ribociclib from the study data we've reviewed. With this patient in particular, again, you're looking at whether she has comorbidities at the age of 76. So how is her overall health? Does she have cardiovascular disease, diabetes, kidney disease, or liver disease? These would be all items that you'd want to consider. And as Seth pointed out previously, with a younger patient, with an older patient, you would want to know how she's going to live like for the next 10 years and how much benefit she would receive, although she'd be eligible for the medication. You'd also want to look at the drug-to-drug interaction with the prolonged QT interval that can sometimes happen with ribociclib. So you'd want to review her medications carefully. So in summary, you'd want to see, is the patient functional? Is she going to be able to tolerate the treatment with the CDK4/6 inhibitor with the endocrine therapy?
Great. Awesome. But being 76 per se really doesn't lower her risk, all other
Yes.
things being equal with regard to tumor biology. Do you agree with that?
Yes, so she'd still be considered high risk at the
Yeah.
age of 76.
Yeah. Unfortunately, it doesn't attenuate with age, does it? If the
No.
biology is the biology, right? Well, thanks a lot, Priya. So, Seth, say a few more words, if you would, about kind of the comorbidities and some of the toxicities of the CDK4/6 inhibitors that you kind of bear in mind.
I agree with all the comments from Priya. More broadly, I might say that the side effect profile that we were discussing a few minutes ago for both of these drugs does impact the way we view potential medical comorbidities. So, for example, a patient who has baseline GI-related issues, whether that's IBS or IBD, might not be an optimal choice for abemaciclib due to the compound risk of diarrhea, for example. A patient who's got cardiac comorbidities and has a risk of arrhythmia, or who are on other medications that might prolong QT, might not be a great candidate for ribociclib due to the QT interactions and polypharmacy. So I think we have to look at the whole picture. It's not just a function of age, as we were just discussing. It's a function of what their baseline symptom profile looks like, what their other medications are, what their other medical issues are, and how that might interact with the potential side effects of these two drugs, which are quite different in terms of the rate of cytopenia, the risk of EKG changes, the risk of GI-related toxicity. And so we have to meet all of these patients where they are as a function of age, functional status, and baseline symptoms and medical issues.
Yeah, thank you. Thank you. It's good that we have a choice, because different patients bring different comorbidities, to our clinic. So I wanted to go back a little bit here and again tweak some of these variables so we can really recognize these patients when we see them in clinic. And I want to ask Priya, this Ki67 in our 56-year-old woman is pretty high at 35. But what if the Ki67 was 15%? Would that change your perception of her risk and what you might recommend to her therapy-wise?
So, for this patient, based on her clinical and pathological features, the patient would still be eligible to receive either abemaciclib or ribociclib with endocrine therapy. And that's based on her tumor size of 5.1 centimeters and the two positive nodes. The Ki67 is reflecting the cancer cell division, and so it's more of a prognostic marker. And so, with a lower Ki67, it suggests that this patient may be more, her tumor may be more responsive to endocrine therapy. So the Ki67 needs to be interpreted in combination with the tumor size, with the number of nodes that are positive to make a decision about the right CDK4/6 inhibitor with endocrine therapy.
Right, and but she'd still be a great candidate for CDK4/6,
Yes,
regardless of the Ki67, just based on the nodes and the tumor
the
size.
tumor size,
Yeah, yeah.
exactly.
Thank you, thanks. And speaking of size, Seth, what if the cancer was smaller? It was T2, like a 2.5 centimeter, for example, rather than a T3. Does that change her risk of recurrence?
These are always challenging scenarios because you're tweaking each variable and you're sort of bringing the patient closer and closer to the cutoff points of some of these trials. I think, again, zooming out and not focusing just on the CDK inhibitor for the moment, having a smaller primary tumor dropping down from a T3 to a T2 would have some impact on her overall recurrence risk, I think, in a positive way, meaning it would drop the recurrence risk a little bit. But I still think most of her risk is driven by the positive nodal disease. So whatever impact it had, I don't think would change the kind of overall approach, our desire to optimize and extend her endocrine therapy and to consider CDK blockade. Now we're starting a little bit to get into the weeds of the inclusion criteria for the studies when we drop the tumor size down. As you mentioned, to qualify for Monarch E, the patients needed to have 1 to 3 positive lymph nodes, high-grade disease, or a tumor measuring T3, right, more than 5 centimeters. That's that first cohort, the primary cohort. That was the majority of the study. They did have the second cohort where patients had grade 1 or 2 disease, had tumors that were less than 5 centimeters, had 1 to 3 positive lymph nodes, and had a Ki67 above 20%. So she would have qualified for that second cohort in Monarchy. And because of that, having all this information, even with the smaller primary tumor, I think I still would have offered both of the potential CDK inhibitors per our discussion. I think if we had started to titrate down even a little bit more, for example, we have a high risk node negative patient. Now we're starting to get into a situation where the patient would not have met criteria, for example, for Monarchy, and we have to check to see whether they would meet criteria for Natalie. But in this case, because of the Ki67, even with the intermediate grade and the smaller tumor, she would still have met criteria.
Yes, and in my practice, I do include that cohort too, that 517 patients who met criteria based on the Ki67 more than 20%. To me, that still is a high risk group as part of the intent to treat a population. So to me, I still think of that patient as very, very much of a CDK4/6 inhibitor, a candidate, both abemaciclib and ribociclib.
I
So
agree.
yeah, I totally agree. So let's talk just a little bit now about how we might distinguish which of these agents to recommend. We have our 56 years old, 2 positive nodes, T3 and high Ki67, grade 2 disease. She would have been eligible for both Monarch E and for Natalie. Maybe Priya, could you talk to us about the factors you consider when you're choosing between the CDK4/6 inhibitors to recommend to the patient?
Yeah, so there's several key factors. So with abemaciclib, that has the longest follow-up data. And as you pointed out, Joyce, in the beginning, that it's also showing now overall survival benefit. We've also seen with the Natalie data that there is benefit as well, but the data continues to mature. With the treatments, abemaciclib is for 2 years with the endocrine therapy, and ribociclib is for 3 years. So these are the discussions that have to happen with the patient related to implications for adherence, toxicity, and patient's lifestyle. And then in terms of toxicity, we've seen with abemaciclib that patients can have diarrhea or fatigue. So as Seth had pointed out, someone who has GI issues, abemaciclib may not be the best fit for them. Ribociclib may be a better candidate. With ribociclib, we see more neutropenia and then the QT prolongation. So you also have to really think about the medications that the patients are taking, not only when initiating the medication, but while they're on treatment, that always checking their medication list to make sure they're not on a medication that could cause a prolongation in QT with the ribociclib. So the duration of treatment, the monitoring of the medication, the side effects have to be discussed for both medications while the patient's starting, but also during the time they're on treatment.
And thank you. And let me just ask you, this particular patient we've been discussing, this 56-year-old, assuming there wasn't a contraindication to either of the therapies, would you what do you generally recommend for this patient here? She's one of those that's eligible for both.
Yeah, so I would tend to go with abemaciclib to offer her, just with the longer follow-up and the overall survival. But ribo is just as good in terms of offering that to the patient, in terms of her eligibility for both of the studies.
She really has an option. And then sometimes when we get into the discussion of the various toxicities and such, patients may really give their opinion and want to know what options they have. And how about you, Seth? How do you approach what exactly to recommend for patients?
I agree with all the great points that Priya just brought up. I think it's fairly straightforward if the patient meets that lower risk Natalie criteria, but doesn't meet the monarchy criteria. And then I think it's quite clear I would offer those patients adjuvant ribociclib unless they had a significant comorbidity or baseline problem where I couldn't give it. When the patient meets criteria for both, those really higher risk patients, the N1 with other risk factors or the N2 patients, I think we're talking about all the things we've reviewed right now, which are other comorbidities, baseline symptoms, baseline laboratory studies, QT. But I also agree with Priya that at the moment, we have a longer duration of follow-up and not just overall follow-up, but follow-up with everybody on the study off drug now for 5+ years with abemaciclib. We also have positive and potentially clinically significant overall survival benefit. Now, my hope is that as the data continues to mature, we'll see the same thing with Natalie, and we'll continue to have two great options for patients. And then it's really going to come down to side effects and patient preference. At the moment, if they meet criteria for both and there's no contraindication, I typically would offer the abemaciclib, but I may mention the fact that we have two drugs and we have other options. And like you said, Joyce, I think having options is a good thing for patients because it gives us opportunities to navigate some of these other factors that may drive us in one direction or another.
Yeah, thank you both very, very much. And that's, I think I'm going to take away from this discussion what you both just said, and I can, my own opinion as well is that the monarch E population is such an enormously high risk population. When these patients have modern day chemotherapy and endocrine therapy, still at 5 years, their prognosis is worse than the triple negative breast cancer patients. That trial really enrolled on purpose this extremely high risk population. And we have now 7 years of follow-up. Everybody's been off at least 4 to 5 years, as you said, Seth, and the curves have continued to pull apart. And now we have survival. Now, Natalie is also coming along with each of the subsequent follow-ups. And now we're up to 5 years. The curves are also looking good and they're continuing to pull apart, but patients have been off of the Natalie trial for a median of a little under 2 years. So we haven't had quite the same duration of follow-up yet, and we don't have statistically significant overall survival, although the curves are just starting to pull apart as well. But it is really, really good that we can cover both the highest risk population with abemaciclib and then the intermediate risk population and our node negative high risk population with the ribociclib. So we really do want to know these eligibility criteria for Monarch E and for Natalie, and make sure we have those top of mind, particularly when we first meet patients and talk to them about what the plan is and really explain to them why they are at high risk. So Priya and Seth, thank you so much for joining and for a really great discussion. Really love listening to you both. And thank you very much for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation. Thank you very much.